Hello everyone, this is Dr. Alex Vasquez with the next video in our program on human microbiome and dysbiosis in clinical disease. This page reviews the usual notices and disclosures, including the fact that this information is protected by copyright, some of it's also protected by trademark, and that I have worked as a consultant researcher and lecturer for Biotics Research Corporation. As you all know by now, what we're aiming for here is a structured approach and a structured understanding of the human microbiome and how to approach this in clinical practice. Now that we're working our way from the molecular microbiology into some of the more clinical considerations, we of course want to consider the four pillars of evidence-based medicine and evidence-based healthcare, which you can see listed here. The fourth video in this program is dysbiosis by location, but before we get to that video, what I wanted to do here was review some concepts and take a quick run through some individual microbes that you are certain to encounter in your clinical practice. So before we dive into dysbiosis by location, I want us all to relax, take a slight detour for a break, and consider a few important details and concepts. Kind of like we're taking a road trip, and we're going to pull over for a minute and take a look at the map. So let's do that now, and let's take a look at this famous quote, which I'm sure you all are aware of, by Robert Frost. Two roads diverged in a wood, and I took the one less traveled by, and that has made all the difference. So we basically have two major paths that we can take when we're approaching the microbiome from a clinical standpoint. One is what we might call the microbiologic approach. That is the focus on the individual microbes. And the way that we can do that is we can do lab tests for everything and then follow that with so-called precise treatment with antibiotics. But I'm sure that even within that idea, you'll see a logical fallacy, and that is no such thing as antimicrobial specificity exists. For example, anytime we identify a microbe, and if we're going to use an antibiotic drug, for example, we might be fortunate enough to kill off the offending microbe that we're trying to target, but of course we're going to do major damage to the remainder of the microbiome, and we're going to impair microbial diversity when we do that. So we want to be very careful about using this approach, which is what we all learn in medical school, and that is you identify the microbe and you kill the microbe. That's kind of ingrained into us, I think, from an early clinical stage in medical school, and it's also part of the kind of Western paradigm, and that is rather than working with problems, we're often taught to destroy those problems. So rather than seek solutions, we seek power and dominance, and we see that translated into the way that we're taught to practice medicine as well. So I think that this approach, the kind of seek and destroy approach, which I used to use, but these days I consider it somewhat impractical and somewhat sophomoric because we know so much more now, and we know that we have other options, and we don't need to treat everything with napalm. So I think this approach does have some application. Obviously, in some very difficult cases when nothing else has worked, then I think we can fall back on this approach. But I do think that we can avoid using this approach to our benefit and obviously our patients' and clients' benefit, and that is to work with their microbiome and restore balance, because we appreciate, as I've already told you and kind of shown you, my model of treating dysbiosis isn't simply to focus on the microbe. Now, in a lot of lectures that I'm sure some of you have attended, the presenters will talk about identifying microbes, maybe killing them off, but what I'm trying to do is to get you to understand that that's only one of many options that we have, and of course we can fall back on that when we need to. I think the microbiologic approach is a way to achieve clinical efficacy when otherwise that efficacy might be evasive, but I also think that doctors use this sometimes when they don't have the skill or experience to employ other options. And I do have a personal grudge, we might say, or at least I'm aware of and sensitive to the fact that some people in medical practice use laboratory tests not because they're necessary, but because they can be justified. And I've seen some patients spend outrageous amounts of money in functional medicine practices to gain nothing. I remember seeing a patient a few years ago with rheumatoid arthritis, and she went to a very famous functional medicine practitioner and spent $15,000 on laboratory assessments and really very little treatment. And I said, you've got to be clear with me. I want to understand what's going on here. Are you saying $15,000 or are you trying to say $1,500? She said, no, $15,000 on laboratory tests to evaluate her nutritional needs and her inflammatory status. And I said, well, what did you get out of that? And she said, well, he said I had an inflammatory disease and that I needed to take nutritional supplements. And I said, well, I could have told you that. You went into his office with rheumatoid arthritis. You don't need lab tests to tell you that you have an inflammatory disease. And in my opinion, all patients have nutritional deficiencies, or at least functional nutritional deficiencies. And so we can address those on day one. We don't need lab tests to tell us that we have permission or that we need to do those things. We can do them because the risk-benefit ratio is quite low. And that's another, of course, very important consideration. When we're using these high efficacy but low danger interventions, we don't need to justify everything that we're doing with laboratory tests, because what we use laboratory tests beyond diagnosis is to refine a diagnosis, especially when the treatment that goes along with that diagnosis carries significant risk. So for example, if you're going to pull out the big guns, as we might say, and use some really powerful drugs, then of course you might want to justify that, especially if you're working within a controlled healthcare system, so to speak, one that where you have some peer review and some supervision, things like that. You may need to justify why you used a certain drug or a certain combination of drugs, for example, especially if they're very expensive or if they carry risk. That's understandable. But a lot of the best treatments that we have for dysbiosis-induced disease are very inexpensive and very safe, so our threshold for justification is likewise quite low. And we certainly don't need to charge these patients $15,000 for a laboratory evaluation that simply tells us they need to take nutritional supplements and that they have inflammatory disease, especially when they're coming in with a previous diagnosis of that disease. So one of the ways I've discussed this is to say that no patient ever got healthier from spending time and money on lab tests. So let's see what we can do without being dependent and without improperly using laboratory assessments. Let's focus on using those assessments when they're necessary, and they're usually not necessary on day number one. As many of you know, I've been inclined to use a more empiric approach, and this is the second of the two paths, first being, again, microbiologic, focusing on the microbe, which, again, is conceptually erroneous. So for a lot of these conditions, now we can always talk about exceptions. We can look at exceptions like reactive arthritis, such like that. But when we're talking about these more persistent, so-called chronic long-term illnesses, we're looking at kind of a complex microbiome imbalance. We don't necessarily need to target specific microbes, even though, of course, we can do that at times. And of course, that is the preferred approach in certain cases. But we don't want to generalize that microbiologic approach to all cases. So with more and more experience, I think we will probably all come to use a more empiric approach. We can prioritize treatments, not lab tests, and then test as needed after the entire protocol has been implemented and residual inflammation needs to be treated. Let me say that one more time, since I only have one bullet point to make on the empiric approach. The empiric approach is to prioritize treatments, not lab tests, and then test as needed after the entire protocol has been implemented and residual inflammation needs to be treated. It's a bit of trial and error, but of course that's very reasonable. And you'll see that some of the best articles that talk about dysbiosis, even, for example, small intestine bacterial overgrowth, what they recommend is an empiric approach, because empiricism is ultimately the data that you need. It shows you what works in the reality of this patient. A laboratory test isn't generally going to give you that information. Only rarely is a stool test or a microbiome test of some sort or another, and I'll review those with you in just a moment. Only rarely in complex dysbiotic diseases are we going to get our answer from that. So rather than rely on laboratory printouts, what I want us to do is rely on a more comprehensive approach and trust ourselves that we can acquire the information and the efficacy that we want, but without using $15,000 worth of lab tests, as I've already exemplified. So I've talked about this before, and like I say here, I make no bones about it. I think profiteering off of patients is a horrible misuse of the social privilege that goes along with being a clinician. And I also quite clearly think it's a disgrace to the founding ideas of functional medicine, which I started studying back in 95, 96, I remember in 1995 and 96, that's when functional medicine really started to take shape. And the whole idea was to become more effective, more skilled, to treat these interconnected illnesses, these web-like connections between the various physiologic factors, which ultimately either promoted health or disease. The idea was not to use the knowledge of those interconnections to justify thousands of dollars of unnecessary but justifiable laboratory assessments. And indeed, I typically put things in writing, and I'm happy to do that. And you can see here in this perspective that I published in Alternative Therapies in Health and Medicine in 2014, I did pretty much put my money where my mouth is in this model that I have, which is we need to prioritize patient care, not, as some doctors have done, patient profiteering. Asking which laboratory test is often the wrong question that will provide a distraction and detour from the right question, and obviously, therefore, the right action. The question that we should always be asking is, what can I do as a clinician to improve this patient's situation? Or you can phrase that in other ways, some reasonable variant of that, but we need to focus on what is going to benefit the patient. Our goal is to benefit the patient's health. The only way we're going to do that is by taking some type of action. Rarely, as clinicians these days, do we take that action, especially in outpatient practices. What we have to do is engage with our clients, our patients, and get them to implement, but it's still action. So let's just say it's a directive toward action with the goal of improving health. The tactic that we use, so you can see here I'm going sequentially from an overall goal to a more focused strategy, and then within each strategy, we have various tactics that we can use to effect the above strategy. So when we're talking about dysbiosis, I've already given you three main areas on which to focus when you're addressing dysbiotic disease, and some of you may have already started to appreciate that even within those three main variables, we have many other variables. So for example, if one of our goals is to promote tolerance, within my nutritional immunomodulation protocol, we've got at least 9 or 10 different treatments within that so-called single protocol. We have other sub-protocols. Again, laboratory testing comes into play only if one of the tactical subcomponents has failed or needs refinement. Hence, by definition, this is not necessarily something we're going to do on the first day. So exceptions to this rule would be that sometimes we want the data, sometimes the patient wants the data, or again, sometimes we have to justify our interventions to our peers or healthcare systems within which we work. So let's go on now and continue this conversation just a bit more about laboratory evaluations, because I know that everyone always asks me about lab tests, lab tests, lab tests. And so I do think laboratory tests are important. You're going to see in some examples that I show you in just a moment that I certainly use them myself, and I've used them to great skill. And sometimes, yes, I've even used them on the first day. But now, sometimes the cases that I'm going to show you, for example, some of those cases are 10 years old. I think we would all expect, and I would certainly expect of myself, that I would have refined my own approach over these years, and I'll show you how I might approach things differently these days. So keep in mind that when you're asking for laboratory evaluation of the microbiome, that basically you're asking for an impossible amount of information to be delivered to you via imperfect methods. We have no perfect assessment of the microbiome, and even if we did, so let's say, for example, that we could print out a piece of paper or basically a volume of a small book on our patient's microbiome. What are you going to do with 10,000 pieces of data? How long is it going to take you to go through that? And what are you going to ultimately do with that information? So remember, the purpose of assessing laboratory tests and the purpose of performing laboratory tests is to gather data, but that data doesn't have any value unless you know exactly what to do with it. And in this case, one of my arguments against the microbiologic approach to microbiome assessment and management is that if you really got what you wanted, which was a complete picture of the microbiome, you would have so much information that you don't know what to do with it. And none of us would know what to do with it. if you're justifying laboratory tests because you want to be accurate, then I think you're kind of deluding yourself, because you're not going to test for the identity, activity, interaction, and impact of tens of thousands of microbial variables. I think that says it quite clearly. We all want to be accurate, of course, but let's not delude ourselves into thinking that lab tests are going to provide that accuracy necessarily. They're only going to tell us a few microbes when we're talking about tens of thousands of different microbes. And so the best we're going to get is a small piece of that puzzle, kind of a small piece of the conceptual pie, so to speak. Neither you nor any computer program nor currently available precision medicine is going to print the answer for you. My point being is you're always going to fall back on a generalized approach with a few specific interventions. So why not go ahead and start with that generalized approach, and then if you need to, then you can seek whatever might be the appropriate laboratory evaluation. I think you'd be better served by rational and occasional use of laboratory assessments to supplement your already skilled overall approach, which again I have designed and implemented as the Functional Inflammology Protocol, and I'm sure you all remember the components of the FIND-SEX acronym. I think many doctors are still intoxicated by what we all learn in basic microbiology, and that is the ideas of Koch and Pasteur, and the idea that microbial identity is somehow equated to disease causality. That is true for acute and the so-called classic infectious diseases, but that doesn't bear out in what we see with microbiome imbalances and persistent dysbiotic inflammation. Medical doctors are definitely trained to over-rely on laboratory tests, and many other types of healthcare professionals follow suit. Everyone seems to be intoxicated by the lure and lore of functional medicine laboratory assessments, as if this is kind of the next stage, or if it's going to provide more information. And of course, sometimes it does. So I'm not discounting all functional medicine tests, but I do think we need to step away from the bar, so to speak, of functional medicine laboratory assessments and reconsider that not all functional assessments are going to tell us what we need, even though they're commercially available. So let's look at what I wrote back in 2006 related to the paradigms that we all learn. And these are basic concept paradigms. And these are important for the development of science, for the development of our ideas. But we don't want to stay kind of tethered to these very basic ideas as more advanced clinicians. So one of the things I wrote here is that one of the problems that plagues many healthcare providers of all professions is that most doctors are still under the spell of the Pasteurian paradigm of infectious disease, namely that pathogenic microorganisms cause disease by causing infection. And I'm sure most of you remember the ideas of Koch, which were very important for helping us understand that above-mentioned relationships. So basically, these two early microbiologists did a great job of helping us understand the cause and effect relationship between certain classic infectious diseases and the causative microbes. But again, those models really don't apply very well to dysbiosis-induced disease. And so if this were a lecture on infectious disease for hospital care and acute and urgent care, I would say do your labs, follow with the appropriate antibiotics. But that's not the conversation that we're having here. We're talking about long-term microbiome imbalances, and these are much more complex than single microbiologic agents causing a single acute infection. So let's go on now and talk about other ways that we need to change our mind about this. Many doctors carry the ideas that microbial identity correlates with disease, and this again is not true when we're looking at dysbiosis. In some cases, we see a pretty good correlation between a single microbe or a single group of microbes, maybe 4 or 5 different microbes, and a certain disease. But generally speaking, with a lot of these conditions, fibromyalgia would be a great example, we're not going to see specific microbes with specific clinical outcomes. Many doctors still carry the idea that they need to identify and determine the susceptibility of each microbe, and again, that's just clinically impractical based on what we know now. Human beings are not sterile beings who then become infected and we need to just address one microbe with one drug, and that one drug is going to specifically target that one microbe. That's probably never been reality, but we certainly know that that's not reality now. We need to think in terms of function. We need to think in terms of the patient's individualized response. And even if we are going to think about microbes in terms of quasi-classic microbiology, Even then, we would have to start talking about microbial function and, again, the response of the human to that microbial function and expression, not simply the microbial identity. So let me just give you a quick example from the literature. This was published in 2008, as you can see here. Just look at the title of this, and the quote from this article is quite nice as well. But notice the change in the conversation. We used to just think about identity and susceptibility. And so the way that you would see that in laboratory assessments, you would look for culture and sensitivity, because you would want to know what is the microbe and how am I going to kill it. But one of the things that we have begun to appreciate, really, believe it or not, over about the past 13 years or so, is that we need to understand microbial function and how that is leading to disease expression. And I've given you some examples of that in the past. I'll give you a few more on the next slide. But again, this whole thing is so much more dynamic than simply identifying microbes. So yes, we're talking about microbial imbalances, but we don't want to just try to hang our hat, so to speak, on the identification of those microbes and then supposedly the successful eradication of those microbes. What we learn in medical school is an overly simplistic idea, and that applies quite well to acute illness, but again, not to chronic, complex illnesses, especially those created by microbial imbalances. What we learn in medical school is to identify individual microbes, correlate those with specific diseases, and then try to determine, either generally or specifically, what is the antimicrobial drug susceptibility of that individual microbe. What that fails to consider is the most important considerations of dysbiosis-induced disease, which are host defense, host tolerance, the individual characteristics of the microbe, which also include gene transfer and antibiotic resistance. So, for example, I remember reading an article about 5 years ago, and this article is somewhere within my library of about 11,000 articles. I remember reading this article that said the model of microbe identification is becoming passé because microbes can have a certain identity based on their structure, for example, or based on their staining techniques, or now based on certain genetic tests. But none of those assessments is going to tell you about the function of that microbe, and especially it's not going to tell you about the function of that microbe and how that microbe